over 100 tramadol. They were wondering if it would be appropriate to dispose of some of the cards, or how they could handle that now.
Um, so that is
Lori Newcomb and Christina George, here today with us, completing or discussing long-term care medications. And I love the title, Getting the Most from the Least. So Lori is a board certified geriatric pharmacist licensed in both Georgia and South Carolina. She has been involved in long-term care pharmacy for over 30 years. Lori graduated from the Medical University of South Carolina College of Pharmacy in 1990 and attended Clemson University in preparation for pharmacy school. Lori has worked for several long-term care pharmacies, and she is currently the lead for consulting team of pharmacists, nurses, and account managers for Guardian at Pharmacy Atlanta. Lori just celebrated her 10th year anniversary with Guardian Atlanta. Congratulations. She has experience consulting for skilled nursing, assisted living, personal care, community living, adult day, and mental health communities. She has presented dozens of times to a range of long-term care and clinical conferences, as well as groups, communities, and other organizations. Lori enjoys sharing her experience and knowledge in hopes that it will continue to improve the lives of the frail elderly that she loves so much. Welcome, Lori. And presenting with Lori, we also have Christina George. Christina is a board certified geriatric pharmacist licensed in not only Georgia, but Michigan and Indiana. Geriatrics has been a way of life, as 6 grandparents and 7 great-grandparents were a major part of her childhood. More recently, Christina and her husband cared for an elderly relative while raising their 3 children. Christina graduated from Purdue University School of Pharmacy and has worked in retail, hospital, home infusion, and long-term care. At Guardian Atlanta, she has worked as a staff pharmacist, a vaccinator, and as a consultant. Christina enjoys helping families understand options they have and decisions they can make to help improve the quality of life for elderly loved ones. Welcome, Lori and Christina. Thank you so much for being here today.
Thank you, Nicole. Appreciate it. And thank you to everyone who is on with us today. I want to add my Happy Nurses Week and my love and appreciation for all of you nurses out there, no matter what your role is. So I'd like to just add my Happy Nurses Week there. And I would like to also just say thanks to our very, very brilliant clinical support team and our education partners. I said, oh gosh, we're last, but it really makes sense now that I have seen the conference. So we're kind of going to tie everything that you've heard about together. So kudos to our very brilliant clinical support team there, Nicole and Aaron and Brandy. Thank you very much. All right, so let's get together and let's see what we're going to talk about today. So I want to define and explore concepts of deprescribing. Deprescribing is, we're going to define it. We're going to look at it. We're going to look at the principles and their impact on patient outcomes. And then we're also going to utilize some evidence-based strategies to optimize that medication regimen across various drug classes. And then, as always, we want to look at a case study to tie it all together. So what we want to do is start out with defining. So deprescribing is the planned and supervised process of dose reduction or stopping of medication that might be causing harm or no longer be of benefit. Deprescribing is part of good prescribing, backing off when doses are too high or stopping medications when no longer needed. So if you look at the history, the FDA was formulated in 1906. And so for the last almost 120 years, we have been, developing new drugs. Let's get a treatment for this, just throughout the history, we have just been, prescribing and prescribing and getting new treatments and getting new drugs, and that's fabulous here in America. However, I'm finally starting to see now that those of us in the healthcare and especially long-term care industries are finally starting to look at what we may be taking medications off, what may not be good anymore. So, I think you have to look at the history of where we've been with drug development over the last 120 years. And then now I think we're finally at a point where we can take a look at some deprescribing. So just keep in mind the part of good prescribing and backing off when doses are too high, or stopping them when they're no longer needed. We're going to really get into that today. Okay, so let's look at what deprescribing is. It is a systematic approach to dose reduction or discontinuing medication. You look at the goals of care, you look at the current level of functioning of your patient, the life expectancy, their values, their preferences, and we're going to talk a lot about patient-centered. This is a patient-centered process. You heard Dr. Nikki Brandt do a phenomenal job explaining what the 4 M's and how a health and age-friendly health system works. And so this deprescribing process is also very patient-centered. It also has uncertainties to it. We'll discuss a little bit of those. But you certainly want that required shared decision making and the informed patient consent. It's not ever about denying anybody effective treatment. Okay. It's also not hospice. As you all know, hospice focuses on comfort and not prevention or cure. So, while there certainly is deprescribing in a hospice situation, it's certainly not, that's not what deprescribing is really for. Nor is it for palliative care. Palliative, of course, can be in any stage of disease, whereas hospice is usually life expectancy of less than 6 months. But again, palliative care is based on those goals of care. And again, there can be deprescribing in palliative care, but that's not really the process we're going to focus on today. And then it's certainly not associated with any disease or stage of life necessarily. And, you hit, okay, at 95, we have to start deprescribing. It's not associated like that. It is a patient-centered process, and it's very individualized. All right, so with that, let's look at the definition of what is polypharmacy. You've probably heard several of the presenters over the last couple of days use this word, but it is defined as taking at least 5 medications, regardless if they're appropriate, not appropriate. And those of you that are with me in assisted living and even skilled care, sometimes we see lots more than 5. So when do we think about then, if we have polypharmacy, when do we think about deprescribing? Basically want to look at, is there a new health issue? Is there an adverse effect or a drug reaction that patient or resident is having? Have they had a recent fall, fracture, dizziness, stroke, any kind of blood pressure change, or are they having continuous hypoglycemic events? You can also look at those residents that are declining. Have they had a decline in quality of life, in their mood, their affect? Are they becoming more frail? It could definitely be medication related. And we do this a lot in our part of the world here in Atlanta, with, people are outliving their money. And so when there's a financial burden, that's a great time to start looking at, what do we really not need anymore? And a lot of times we can cut out a lot of medication from, a resident's profile. And then pill burden is a big thing. And I see it especially in my memory care and dementia residents, they're taking multiple pills multiple times a day. Is that really necessary? So that's really what we can, begin to think about when we're thinking about deprescribing. And then, of course, any inappropriate medication due to the prescribing cascade. Um, and then what really is the trouble with polypharmacy? Well, you've got a decreased quality of life, and you'll hear me say that multiple times throughout the presentation. Because if they are taking medications all the time, Christine and I were just talking about a resident that literally is taking meds all day. They can have increased mobility issues. They can, of course, have increased mortality. Lots more drug events, lots more interactions. They're going to be in the healthcare system more because they're having adverse drug events, they're having more side effects and interactions. Then you also increase the risk of med errors. When you have multiple medications, you have multiple opportunities to make medication errors. And then, you're going to have increased time. I talk with my, administrators, my executive directors, my wellness directors, and other, community administration, how just the fact that you have such a high, usage of medications in your community can affect your nursing time, your nursing staff time, your CMAs, your caregivers. It's really incredible how much more that it can affect, and of course, it affects the physicians and the pharmacy as well. So let's look at who's at risk for polypharmacy. Most of our people, our residents and our patients are at risk. Of course, long-term care is number one on the list. So 91% of long-term care residents, no matter what their setting is, take at least 5 medications daily. As you know, older adults have more complex and multiple health conditions. And so, but the thing that we don't often think about or really evaluate is, are they really having benefit from these? And a lot of times they're not. They're not having benefit from their medication therapy. They have more adverse events, and a lot of times they die before they reach the therapeutic benefit of the drugs that they're on. So we will talk about that. And then the other, perhaps maybe not long-term care related, if you have a different setting, is those patients who are chronic pain patients. They're going to have a lot of medications. Any of our developmental disability patients are going to have multiple medications, multiple chronic medical conditions. Of course, that goes right along with, there might be 3 or 4 medications indicated for each medical condition. And then mental health. Unfortunately, with our mental health conditions, also you see a lot of polypharmacy and unnecessary medications. We see when a resident or a patient sees multiple specialists, anybody over the age 62, we're going to see more medications just because of physiological changes. Those folks with cognitive impairment are going to be at risk for polypharmacy. And lack of a primary care physician. If you go to, if urgent care or a local clinic is your primary care, or you're going to different places all the time, it's very difficult to keep track of, nobody's watching what you're taking overall and that sort of thing. And then of course, increased fragility is also going to increase the risk of polypharmacy. And then the health system can also contribute to polypharmacy. So, there's a lot of guidelines, and we're talking about guidelines today, but the good news for us is we're talking about deprescribing guidelines. But, if most of our physicians are going to try to adhere to very strict guidelines on prescribing, and a lot of times that can mean extra medications, and maybe not every patient needs that. Quality of care measures. If you're trying to, if a healthcare system is trying to meet their quality of care measures, well, they need to be on, these medications to meet the quality of care. And then we all know about transitions of care. We see it all the time. And I think Dr. Brandt this morning did a transitions of care case study, and where things aren't carried over, and information is not carried over, and so you can see a lot of polypharmacy and people left on medications they don't necessarily need during that time. Automated refills, of course. We see, I want to know how many nurses out there get, your new potential residents, and they bring in bags of medications that they have 6 months worth. And where did you get all this? And then, of course, poor medical record keeping. I know a lot of our electronic records don't talk to each other, and so that can also contribute to polypharmacy. So if we want to look at then how to start deprescribing some of the principles, we want to take a systematic approach, and we're going to look at it in several different ways. We always want to be patient-centered. We've talked about, again, the health, the age-friendly health initiatives, and so we always want to be patient-centered because this is about each individual patient. And then as pharmacists, we always are taught to utilize evidence-based strategies. If you know a pharmacist, you're going to, I know at some point here, what's the evidence in that? My family hears that all the time. What's the evidence that says that that's good for you to take? So it's, always you want to make sure that anything that you're taking does have evidence to back it up. All right, so if we use that patient-centered deprescribing, we can improve mobility and safety, we can optimize cognitive function, and we can address polypharmacy. And you say, well, Lori, how can I do that? Well, let's take a look in depth here. Okay, so improve mobility and safety. We might be able to um, aid in adding a walker or an assistive device. We might be able to address some nocturia. Of course, medications are always, they're gonna improve that mobility and safety because we may be taking some away. But as we're evaluating that patient, we might be able to improve their vision and hearing. Maybe they're not wearing their hearing aids or their glasses. Okay, so the other thing we can do with deprescribing is we can optimize cognitive function. So again, we're going to look at those medications. What medications are causing cognitive problems? We're going to maybe look at their activity and their physical therapy. Again, Dr. Brandt talked about this morning about how the resident was not out in the sunlight, and so they weren't sleeping appropriately, and that sort of thing, and they weren't walking during the day, and those sorts of things. So those are always very important. We may be able to find some lab abnormalities. When you really get into evaluating these residents and patients, you really get to see, what's causing some of their cognitive dysfunction. Are our residents, are they socializing appropriately? Are they having increasing isolation? Are they depressed? And just, maybe they might be depressed and their therapy is not effective. And then, of course, address polypharmacy. FRIDS is fall risk increasing drugs. And so that can cause a huge medication burden. Anticholinergic burden, we're going to talk about. That's just where a patient has a multitude of anticholinergic drugs, which sort of add and they pile on each other. And then we've got harmful medications that they may be on. And we've got drug interactions that also that we can address. And then over and under treatment. A lot of times, as I said, in depression, they may be treated with an antidepressant, but is it really working? And so, is it really doing what it needs to do? And so you've seen this multiple times, and we said, Dr. Brett did a great job at presenting this morning. But again, anytime you're patient-centered, you always want to start with what matters. What matters to that patient, or if that patient is not cognitive, what matters to that family or those caregivers? What's most important? What kind of end of life care do they need? What medications do they believe in? We have to look at, culture and how they grew up and where they grew up and those sorts of things. So what medications are important to them? Mentation, again, what is causing cognitive dysfunction? Can we identify? Can we treat and manage their dementia? Can we treat delirium across any setting? And then mobility. People want to be able to still move. They want to be independent. They want to be able to go get their own glass of water or go, pop something in the microwave. So that's all very important. So anytime that we are deprescribing, we want to remember the 4 M's of the age-friendly health system. And then here is a schematic that Christina and I both we're going to utilize when we get to our case study, but we want to just take a look at it. And it's also written in your handouts as well. We'll look at that next. But I'm not going to go through all this, but the whole idea is I want you to see is that this is a circle. It's basically a never-ending process, and there really should be another arrow between after you complete the first medication, and providing monitoring and support. And then you just go again. We're going to review that history again. We're going to identify, the inappropriate medications or things that could be just deprescribed. And so we're just going to keep going around. So you just remember, just always think of the deprescribing process as a continual diagram. And so here the process is just written out. And it's not in a schematic, but I wanted to put it so that it would be a little easier to read as well. But again, start with that medication history. You want to keep that, that patient's goals and preferences and all of it, that what matters to them at first. And then once you get that medication history, then you can identify, inappropriate medications. And then another thing to remember in your deprescribing process is that you have to get everybody involved. And that's what Dr. Nikki Brandt was talking about this morning when she was talking about when you want to be an age-friendly health system or a healthcare community. You have to get all members of the healthcare team just participating in a discussion first. And then people in long-term care communities and their families and caregivers need to participate because it is shared decision making. I talked about that earlier where, we want them to establish their goals and we want to know what matters to them concerning their medication use, the effectiveness, the safety. And then I am a big proponent of any non-drug alternatives. And then all healthcare providers and personnel, we have to teach and train and make sure they understand that they're looking for signs and symptoms. When I teach our CMAs here in our state of Georgia, I teach them that you're always looking for signs and symptoms of change. And so we just need to teach our caregivers and our dining staff and our cleaning staff and everybody that comes into contact with our patients that, observe for those signs and symptoms of any changes. And those are what we need to know about. And then our prescribers, of course, they need to document the reasons for use, their goals, the timeliness of each medication, and then basically how every resident is doing. So some resources that we have are that we're going to talk about today. There are multiple resources out there, and I know you've heard about several of them over the course of the last couple of days, but we have deprescribing.org, which is one of mine and Christina's favorites. We're going to talk a little bit about the anticholinergic burden calculator, which is a great free resource for you. And then there is the Beers criteria as well. So with that, I'm going to turn it over to Christina, and she's going to talk about some of the evidence-based guidelines and algorithms that deprescribing.org has. And just so you guys know, there are pamphlets. This is the best website, and it is free. They do PPIs, antihyperglycemics, benzos, Z-drugs, antipsychotics, and cholinesterase inhibitors. There's pamphlets, there's brochures, there's videos. So there's lots and lots of great information out there. So we're going to take a little bit of time now and talk about deprescribing algorithms of some of these drug classes. Okay, Christina.
Okay, the proton pump inhibitors. This guideline recommends deprescribing the PPIs, which can mean reducing the dose, stopping the medication, or switching it to an on-demand dosing, such as a PRN, in adults who have completed a minimum of 4 weeks of PPI treatment for heartburn or mild to moderate gastroesophageal reflux disease or esophagitis, and whose symptoms are resolved. Some people will need 8 to 12 weeks, depending on the situation. These recommendations do not apply to those who have or have had Barrett esophagus, severe esophagitis grade C or D, or documented history of bleeding gastrointestinal ulcers. The PPIs are a great set of drugs. I was reading about a gastroenterologist who was saying that when they're used correctly, they're the best things, but they do need to be deprescribed at some point. For most people, not everybody. Concern about overuse of the PPIs has been growing. In a report that was summarizing prescription use in Canada, pantoprazole was the 5th most common drug prescribed, with more than 11 million prescriptions dispensed in 2012. That's a lot of drug. The most common indications are for things such as GERD, which requires a short-term treatment, which is only like 4 to 8 weeks. But chronic use appears to be problematic. Prescribers are not deprescribing them. Residents, patients are not asking to be taken off of them either, with studies showing a lack of documented ongoing indication for between 40 and 65% of hospitalized patients in the US and Australia, and for between 40 and 55% of primary patients in the US and the United Kingdom. So there's no reason being given for them to stay on these meds. Proton pump inhibitors are often viewed as being safe and well tolerated, but they do have side effects, which can include diarrhea. It can impaired absorption of vitamin B12 and magnesium, increased risk for Clostridium difficile infection, which is a very difficult infection to get rid of, hip fractures, pneumonia. These incidences are small, but older individuals that we see in our facilities are at much higher risk for these conditions. And when PPIs are inappropriately prescribed or used for so long that they're not even needed anymore, they can contribute to polypharmacy and all the risks that come with that of non-adherence, prescribing cascades, adverse reactions, medication errors, drug interactions, emergency department visits, and hospitalizations. So this is from deprescribing.org. It goes through asking questions to ask when you're looking to take somebody off of a PPI. But again, over here on the right, if they have Barrett's esophagus, chronic NSAID users who have a bleeding risk, severe esophagitis, or documented history of a bleeding GI ulcer, they need to be continued. Definitely consult with the gastroenterologist before doing anything with their dose. The rest, you can see there's a lot of uses where they're saying, you know, it's just needed for short term, and then we need to be taking them off of it. But depending how long they've been on it and what else is going on, as to if we can just stop it or if we need to decrease their dose, do take this, look through it carefully, and then take what applies to your situation. I can't go through in all this detail and have someone monitoring every day when I make these recommendations to my ALF residents, but I can do like 2 and 4 week intervals and know that somebody will monitor and be on top of it. Our anti-hyperglycemic drugs are also up here on the list that prescribe has recommendations on. It's recommended to deprescribe these medications known to contribute to hypoglycemia. Older adults are at risk for hypoglycemia. You also want to look at in situations where the anti-hyperglycemic medications may be causing other adverse effects as well. And you want to individualize targets and deprescribe accordingly for those who are frail, those who have dementia, or have a limited life expectancy. These individuals in particular are at increased risk for the hypoglycemia, and we all know hypoglycemia can lead to falls. Again, older adults are at increased risk for this due to impaired renal function. Their kidneys are not functioning the way 20-year-olds are. They're more often to be dehydrated. Most of them will have where the family's brought beverages in, it's in the refrigerator and it's on the MAR to remind the staff to encourage them to take a drink. They will have polypharmacy, so they have multiple meds. Some of these may be inducing hypoglycemia as well. unintentionally. They have a slowed intestinal absorption, so they're slower to absorb their food, so their blood glucose level may not be getting as high as it did 10 years ago when they started with their diabetes diagnosis. And they have decreased hormonal regulation. All these work together, and once again, we're risking hypoglycemia, which can lead to falls and all the problems that go with that. Which ones are recommended for deprescribing? Sliding scale insulin. Avoid this. It can increase hypoglycemia without any improvement in the hyperglycemia management. Never know if people are really going to follow the scale. Is the right amount of insulin going to be injected? It causes more problems than it solves. Sulfonylureals, these also increase the risk of hypoglycemia. It is best to discontinue them. Beer's criteria, which we will talk about, also now has them as to just plain avoid. And other agents used based on the goals of therapy and comorbid conditions and side effect profile should also be considered. The anti-hyperglycemic drugs, when a person is first diagnosed, they tend to be younger. They're more motivated to decrease their blood sugar levels. They have more resources. They have fewer other health incidences, health comorbidities. So it's more likely that we're going to have a lower A1C for them. But then as people are getting older, they start to get more other health conditions. They're less motivated. Their eyesight may be failing, so it's harder to do, finger sticks all day long. It's harder to read, harder to see what they need to do to account for the higher blood glucose level. It's harder to take the meds. So they reach a point where it's probably best to just not even worry about the A1C. And instead of worrying about the glycemic control, we should be worrying about decreasing hypoglycemia and treating symptomatic hyperglycemia. So decreasing the meds and deprescribing these is usually the best option. And again, there's another algorithm for deprescribing the anti-hyperglycemics. Questions to be asked, things to look at, what's the condition, what's their life expectancy, or have they had an incidence of hypoglycemia, what else was going on, what medications are they on? You can take this and go through it. There's a lot of good information in there to be applied. And we have our benzodiazepines and our Z drugs. The long-term use of benzodiazepine receptor agonists, including the benzodiazepines, for insomnia is common in adults and the elderly in both community, primary care, and institutional practice. Chronic use of these can lead to physical and psychological dependence. Many think, oh, if I don't take my tablet, I'm not going to be able to go to sleep, when really they probably could. New evidence has emerged suggesting that the efficacy of these for insomnia can diminish within 4 weeks, which is shorter than we used to think, but adverse effects can persist well beyond those 4 weeks. It is recommended that deprescribing, which is tapering them down slowly, not cutting them off immediately, be offered to elderly adults who take the benzodiazepine receptor agonists, regardless of how long they've been on it. Deprescribing should also be offered to those who are 18 to 64, which we are seeing more of the younger individuals in our facilities for various reasons, and they also are using the benzodiazepines, so they need to also be offered the option to deprescribe. These recommendations apply to the patients who use them for treating insomnia on its own, which is primary insomnia, or if they have comorbid insomnia where potential underlying comorbidities are being effectively managed. It does not apply to those who have other sleep disorders, untreated anxiety, depression, or physical and mental health conditions that might be causing or aggravating insomnia. So it's very important to know why they're taking it in the first place. The benzodiazepine receptor agonists are associated with harms, and therapeutic effects might be short-term. So the benefits and the risk may not be equal here, and the benefits may not be greater than the risk. These harms can be increased risk of falls. They can have motor vehicle accidents, memory problems, and daytime sedation, especially in the elderly. Mrs. Smith may have been wandering through the facility during the night and not have any recollection of it the next day. Tapering them is better than cutting them short because it does improve the discontinuation and getting off of it and staying off of it. Deprescribing.org has some great brochures that go over talking about how to do this, things for the family to look at and talk about. You definitely want to make sure they're on board for deprescribing. and questions that the family and or the resident can ask their doctor at the next appointment. And here's the algorithm they use for taking it. Again, wanting to know why they're on it, what's the started for it, reasons to not stop it. Definitely they should talk to their doctor before adjusting any dose. Alcohol withdrawal, I've been seeing a lot of alcoholics in our facilities in the last few months. A lot of times they're on it, they need to stay with their doctor and only change their dose with the doctor's consent, which all of them should be with the doctor's consent, but I would not touch those at this time. You definitely want to engage the patient and their family to make sure they're on board for doing this and they understand why it's important to do it and that they will have a greater impact by prescribing it and just using it as needed than if they take it every day. And Lori will get back to the antipsychotics.
Thank you, Christina. Yeah, so still continuing with the deprescribing.org, then we have antipsychotics. And again, you've heard a great presentation yesterday on psychoactive drugs, but you know, all of us in long-term care, no matter the setting, we're seeing so many antipsychotics. And typically we're seeing these used to control behavior and psychological symptoms. So we call that BPSD, which is behavioral and psychological symptoms of dementia. Those can include delusions, hallucinations, aggression, agitation, and where there's a potential for harm to the patient or others. And you've heard that before, and that's really a justification for using it. What happens though is I think that the residents and patients get on these drugs and they don't necessarily ever get evaluated and taken off. So there was it's fairly old, but a 2014 meta-analysis demonstrated that statistically significant improvements in symptoms of BPSD as measured using 5 different scales for patients taking up atypical antipsychotics as compared with placebo. So basically, you know, they were as good as placebo. Antipsychotic treatment initiated it's often just continued chronically, as I said, and despite a lack of ongoing evidence whether or not it's working, I even see, you know, sometimes somebody will add or a doc will add a second antipsychotic, or they will have multiple uses while they're on an antipsychotic for behavioral symptoms. They'll be on PRN lorazepam or a PLO gel. And so you want to say, hey, you know, this antipsychotic is probably not working. So a lot of times when it is initiated for the behavioral and psychological symptoms, they're not always effective. As you all know, antipsychotics are associated with numerous side effects, and there's a big black box warning, and they are not indicated at all for the use in dementia because they do increase the overall risk of death and cardiovascular events. Your atypical antipsychotics can cause weight gain. They can precipitate or worsen diabetes. They can also precipitate or worsen incontinence. And while the absolute risk of a lot of these events are small, of course, older adults are going to be much more susceptible to these. You look at the CMS requirements in long-term care facilities and for skilled care, the regulations require that the medication is only given if clinically necessary. They have to have an Ames test every 6 months, and a gradual dose reduction evaluation is required in a skilled building. Whereas in ALF, none of that is required. And so you can have patients that have been on antipsychotics for years and years, if they've had dementia for years and years, and they've never been dose reduced, they've never attempted a gradual dose reduction, and they may not have had any behaviors in years. So if the patient is stable, I know this doesn't sound to some healthcare providers, you say, well, if they're stable, I'm just going to leave it alone. But that's not necessarily the case when you're looking at antipsychotics. You really want to consider a gradual dose reduction. You want to involve, if your patient has a psychiatrist, you certainly want to involve that psychiatrist in that deprescribing as well. And just so you know, about 20 to 50% of long-term care patients are prescribed an antipsychotic for a non-psychotic indication. Again, you're going to risk mortality, stroke, and cognitive decline. It's recommended per the evidence from deprescribing.org that you deprescribe antipsychotics for adults with behavior and psychological symptoms for at least if they've been on it for 3 months, the symptoms are stabilized or there's been no response, and for any adults with primary insomnia, if they're treated with an antipsychotic. It's also recommended that after 3 months that you can try to deprescribe. The guideline does not apply to all these any psychiatric illness. These listed here: schizoaffective disorder, bipolar, acute delirium, and those sorts of things. So those are not included when you are working on deprescribing. Also look at those residents that are taking antipsychotics as an adjunct for depression. If you watch television, it's advertised, if your antidepressant is not working, you can take this drug, and it'll make you feel better. So look at that, because that a lot of times it may not be effective. If it is effective, that's great. And you want to talk to the prescriber about that. But if it's not, that's certainly an indication for deprescribing. And so here's the algorithm again. Christine and I just wanted to share these because you can share them with your providers, your physicians, your nurse practitioners. It gives you lots of information and lots of steps on deprescribing. The last class we're going to discuss is cholinesterase inhibitors and memantine. And I get lots and lots of questions on this. Does mom actually need this forever? So, of course, as you know, people with dementia can be prescribed a cholinesterase inhibitor, donepezil, rivastigmine, or galantamine, and or memantine to treat the symptoms of dementia. The deprescribing guideline discusses when is it suitable to deprescribe or withdraw these medications. And there's a lot of information that we won't just delve into very deeply today, but just so that you can have food for thought, you really want to look at, of course, discontinuing it if it's leading to any worsening of cognitive function. And there's really not a lot of data on person, outcomes or person-important outcomes such as quality of life and function, because the patients that are on this, they really can't communicate those things. So that's why there's not a lot of data out there. But there is a considerable amount of uncertainty in the benefits and the harms of both prescribing and deprescribing these drugs. So a lot of times our providers are in a quandary as to what to do. So if you have patients on cholinesterase inhibitors like donepezil, rivastigmine, or galantamine, you really want to look at, have they been on it for more than 12 months? And feel confident in recommending a trial of deprescribing if the cognitive and or function has significantly worsened over the past 6 months. As you all know, any dementia, and especially Alzheimer's dementia, they're going to have their good days and their bad days. They're going to recognize a daughter or a son, and then 2 weeks later, they're not going to recognize a daughter or a son. So, they're going to vary. But if overall the function or cognition has significantly worsened or declined, that's a good indication that their cholinesterase inhibitor or their memantine is really not functioning as it should anymore. If you haven't seen any benefit, I have a lot of family members that tell me that, hey, I've not seen any benefit, or I've just seen an actual I've not seen any decreased rate of decline, and so that is when you really want to look at deprescribing that drug. And then again, for any individual with severe or end-stage dementia, there's no reason to keep them on a cholinesterase inhibitor, because they really are indicated for mild to moderate dementia. And once that resident or patient crosses that threshold, there's really no reason to keep them on that drug. So that's a good indication to deprescribe. Other situations where you might consider is if, it's just a decision by the person with dementia or their caregiver, they need to discontinue it, maybe for financial reasons. A person, who's refusing it, they're not taking it anyway. That's a good time to go ahead and deprescribe, or non-adherence. They're at home per se, and they're not taking it appropriately. If you run into drug or drug disease interactions, if they're having severe agitation or restlessness that just won't, resolve, probably they don't need that cholinesterase inhibitor anymore. And then if they have a non-dementia terminal illness, there's really no reason to continue that acetylcholinesterase inhibitor. Again, here is the algorithm, and you can give it to your providers. Take a look at it. It's great information. Again, this is from deprescribing.org, and it goes through a lot of great information there. Okay, and I'll talk really quickly about the anticholinergic burden calculator because we want to get to the Beers list and then get to our fascinating case study. So this is a great tool that anybody can use. You just go to acbcalc.com and you put your medications in, and it gives you a score. And so as you can see here, I use temazepam, quetiapine, and oxybutynin, which is ditropan for bladder control. And so as you can see, this particular resident, and I know you can probably name 17 residents in your ALF right now that are on all three of these, they have a high risk because anything 3 or greater is considered high risk and anticholinergic effects. And just remember, those are dizziness, dry mouth, orthostatic hypotension, definitely increased confusion, dizziness, and all those things can lead to falls. And so you really want to look at that burden. So if you just are interested, if you put a drug in and nothing comes up, that means it really does not have enough anticholinergic effect to be considered. So don't think it's not in there. It's just it doesn't have enough to be considered worrisome. All right, and I'm going to let Christina come and talk about Beers list, and then we're going to get to our case study.
Okay, the Beers list got started for because Dr. Mark Beers in 1991 was concerned in the 80s in the nursing homes. He wasn't seeing any kind of guidelines. He was worried about what residents were getting. So he pulled 13 of his peers who were also experts in that field, and they put together the first list, and it's been going ever since. So it will list medications over here, and then it'll tell you whether to avoid them or if they are potentially inappropriate for this age group. And then it gives you reasons why and tells you what the evidence is for why they've made those suggestions. The intent is for practicing clinicians to utilize when caring for adults who are 65 years and older in ambulatory, acute, or institutionalized settings of care. It's to reduce older adult exposure to potentially inappropriate medications. The recommendations are either avoid, meaning the medication should be avoided, except, and then it will list like unusual circumstances where it might be okay or a safe reason to even use, or it will say use with caution. The medication raises concerns, but the evidence may be limited or it lacks consistency. And the most recent update in 2023 includes that glipizide is now added to the potentially inappropriate medications. It says to avoid the sulfonylureas for diabetes. Anticholinergics were added to the medication list, saying to avoid them unless safer alternatives are not available. It's like on what you could use the anticholinergic calculator to help see what are ones that are in there, and sometimes it will list alternatives for you. So now let's pull this all together. This is the fun part where we get to go to our case study. And this is a resident that came across not too long ago. She's a 93-year-old female in memory care in an assisted living using the facility physician. Her diagnoses include Alzheimer's disease, heart disease, hypertension, hyperlipidemia, diabetes, and GERD. She eats about half of her breakfast each day and a quarter to 50% of her lunch and her dinner. And her blood sugars are all like 100 or considerably less, and she has no drug allergies. She is verbal, but she's not able to communicate appropriately. She seldom recognizes her daughter and her son-in-law, and she thinks that her son is her husband, but her husband passed away 14 years ago. She requires assistance with all of her activities of daily living. So for toileting, she's incontinent and needs to wear a diaper. She needs help with transfers. She needs help walking, bathing, eating. Her son and daughter are very attentive and caring. However, they do not want to put her on hospice. And here's her meds. She's got aspirin 81 milligrams every day, atorvastatin each night, Suboxone film twice a day, calcium carbonate chewables twice a day, docusate sodium twice a day, escitalopram every morning, famotidine twice a day, pantoprazole 40 milligrams daily, which I was able to find was started during a hospital visit 4 years ago. Not sure why though. Vitamin K, D, and D3 daily, memantine twice a day, methylcarbamol that she takes at bedtime and started over a year ago, metoprolol twice a day, mirtazapine at bedtime, her PEG powder in liquid every day, quetiapine that was started a year ago, just at bedtime, cranberry capsules, her Senna, temazepam, which started 5 months ago, glipizide twice a day, and cinnamon caps 3 times a day. Her PRN meds include Humalog via a sliding scale, though it has not been needed except for 5 times in the last 3 months, and Milkamag twice a day, but as needed for constipation, but she has not been needing that. So where would you start? Lori?
So Christina and I are going to kind of do this together because this is what we do every day.
Every day.
And so what we thought we would do is to tell you, sort of how do we start when we look at this medication profile? So the first step again is always to find out what matters to that patient, or in this case, what matters to the family, the son and the daughter. We know that they're very caring, they care about mom, and what are their goals? What do they see? Mom's 93, she's got, dementia. She is towards the end of her life or at the end of her life. What's important to them? What are their expectations for her life expectancy and functioning? And as I'm sure you really have to make sure that, as you're listening, as you are the healthcare expert, is as you're gathering their goals, you want to make sure that their expectations are reasonable. And if they're not reasonable, maybe you guide them either yourself or you guide them to other resources, maybe their physician or nurse practitioner, because not all family members have, reasonable expectations. So, you want to make sure that you know those, but again, you make sure that they're reasonable. And then here's my favorite. Start with any medications. I call this the low-hanging fruit. So any medications that don't need tapering and have no current indication, that's easy to do. And then look for duplication of therapy of medications. And then based on what those goals are, you can begin tapering and discontinuing medications that have been identified as no longer needed. So what we could look at then is, Christina, what would you do with sliding scale insulin and glipizide?
I would discontinue those right away. Her blood sugars are well within normal range. If anything, they're tending on the low side. I would get them. I'm surprised they haven't been stopped already.
Right. And, it is taught that anytime they're on less than 10 units of insulin at a time, you can really get rid of it. And especially in this case, we could just stop both of those. Atorvastatin?
She has less than 10 years life expectancy. I would stop that as well. Potentially, she's having some muscle pain possibly from it. So why put her through that? Let her stop it.
Exactly. And why is she on Suboxone?
I could not find any reason. I was surprised to see it. She doesn't even have a PRN acetaminophen. There's no indication of pain. I have no idea why.
And just so you guys know, Suboxone is a treatment for opioid use disorder. And she has no indication she's not on an opioid, but yet she's on Suboxone. We have no idea why. My PPI expert, what would you do with famotidine and pantoprazole?
I would taper her off of those because she's been on them long enough that she's potentially gonna have reflux on her acid, but I would definitely be getting her off of those. There's no indication for her to stay with it. She's having to take it. It's inhibiting her absorption in her stomach further. It's not needed. It's an expense also.
Absolutely. And then there's the supplements. Certainly not my favorite. Go ahead and at this point, we can get rid of all of them. She's not walking on her own, so she probably doesn't need her calcium anymore. She doesn't need her D3 and her vitamin K. She doesn't need cranberry caps. She doesn't need cinnamon caps. There's lots and lots of things that she, does not need. Aspirin, of course, there's guidelines now where you don't, it's not recommended for primary prevention because in older adults, it increases the bleeding risk. So, used to we put everybody on aspirin and take it forever. That's not the case anymore. And then, of course, her Senna and peg powder and Docuzate can probably be, depending on her bowel habits, can be deprescribed. And then methocarbamol.
I would discontinue that as well. I would probably taper it though, because she's probably physiologically needing it still. So I would taper that off. But I think when that, along with the Suboxone and the quetiapine are stopped, I think she may be more alert. She may be more talkative. Her conversation might be more contemporarily appropriate. She may even recognize that her son is her son. And maybe not. We won't know until the meds are not there anymore.
Absolutely. And then, of course, for the temazepam, again, we definitely want to stop that because she's such high risk of falls. And studies have shown it's not even effective after 4 weeks in some cases. And then she's got a duplication of antidepressants. So we could probably stop mirtazapine. We may want to leave the escitalopram. But again, anything psychoactive, you do need to taper and taper one at a time and very slowly. All right. So with that, I will, I don't know where the thing is. I will turn it over and see if there's any questions.
Perfect. Thank you so much, Lori and Christina. We appreciate your expertise on this. This was a great presentation, very educational. I do have a couple questions that have come through. So the first one is, I have a resident on hospice who is still taking at least a dozen meds. Should I approach the hospice nurse to discuss having some DC'd?
I would say yes,
Absolutely.
absolutely. The resident's having to take lots of meds. She's not needing to. Her quality of life is being impacted by having to take meds, filling up on fluids all day.
Yeah. And as we saw, hospice should be, less than 6 months life expectancy. So definitely, those meds that are preventative, the preventative medications or anything that is being used, the supplements, things like that, they can all go away.
And they want to make her comfortable.
Exactly.
Be annoying her taking meds.
Taking meds all
Most
day.
residents don't like taking meds all day.
Exactly.
Right. Perfect. Thank you. And then another question that has come through is, what are your thoughts on medication management of mood-altering drugs by outside online providers that never see the individual personally? I'm mainly thinking in the case of dementia residents who cannot provide a personal history of mood or behaviors. And I imagine they're referring to telehealth then as well.
That's hard because I know that depending on your area, finding a good provider is difficult, but I guess if I, if possible, I would definitely not, have telehealth for mood altering and psychoactive drugs, because that they really need to be with that patient and see them. Do you have any thoughts on that? That's
I guess
hard.
it'd be better than nothing, than just
Right.
leaving them on the meds and doing nothing. So at
Right.
least somebody's overseeing it, but
Right.
in person would be my preference.
Right. That was a good question.
It was a great question. Any other questions that we have out there while we have about 1 more minute and we have Lori and Christina with us? I'll just leave that. It doesn't look like anything is coming in. The CEU form and evaluation has been posted within that chat there. So you can certainly do that right away if you'd like. And then we will also, again, send that email out by the end of the day for the handouts and evaluations for all 3 sessions. And I will turn it over to Erin.
Thank you, Nicole. Thank you, Lori and Christina, for the great presentation, and to all of our speakers today. I just want to thank all of you attending. Thank you so much for being part of Guardian Pharmacy Services Annual Clinical Symposium. We hope that the information that was presented over the past 2 days has been beneficial and informative for you. A big thank you to each of our speakers. I know most of them aren't on right now, but we so appreciate you sharing your time, your knowledge, and your insights throughout the day. Also, thank you to Lisa and the AME team for helping to coordinate the program. If anyone has questions regarding the CE reporting, please reach out to Lisa at, her email is lisa@medicationeducation.org. I hope she can drop that in the chat for easy reference. But as a reminder, like Nicole said, those emails will come out here shortly with links to the CE evaluations for all 3 sessions today. If you've not filled them out yet, please do so through there. Those links to the presentation slides will also be included. Just a reminder, the pharmacists and nursing home administrators CEs will be directly reported to NABP and NAB respectively. Nurses and others that aren't included in those groups, you'll receive a certificate from AME sometime next week. So keep an eye out in your email for those, and you can use those for self-reporting to your board or organization. Please reach out if you need further assistance with anything. Again, thank you for choosing to share your time with us the last couple of days, and I hope you have a great weekend.